Okay, thanks very much, and thanks very much, Steffi. It was really, really interesting talk there, and I'd really like you all to bear that in mind whenever you're looking at these slides, because what I'm talking about is risk factors for admission. My name's Mark McCann, previously of Queen's, now from the University of Glasgow. This study was also based in the NILS, and it was looking primarily at risk factors for admissions to care home. The primary risk factors are, as you'd expect, would be older age. It's no surprise that everyone's getting older. The population is also, the average age is increasing. This is well known and can be predicted forward, but besides age, there's other large demographic and social shifts in the population that we need to think about in terms of forecasting the requirement for care. In particular, we know that families have changed over time. Family sizes and the number of children has tended to get smaller. So in terms of the informal care resource, that pool is decreasing. Also in terms of living arrangements, people are tending to live in smaller households. It used to be there'd be extended households, a couple of generations in the one house. Now it's much more common to live as two-person households in older age. If this trend continues forward, this may have consequences for the need for care. Also, in terms of the economic upturns and downturns, we can be pretty certain that the current economic crisis and the number of people that have been pushed into poverty, we can be certain that this will be reflected in poor health of people in 30, 40, 50, 60, 70 years' time. The poverty gap will lead to long-term health inequalities, so we can predict that, we can be certain of that. So in terms of looking at social factors today, by having a better understanding of the shape of the population and the shape of the use of care homes, I can give us a clue about how these social factors are going to lead to health and health service utilisation in the future. So this is really using population research to try and plan forward for long-term policy planning. In terms of the data set I'm looking at, it's similar to what Steffi has talked about. It's the Northern Ireland longitudinal study. In particular, it's focusing from 2001, so it's looking at an earlier time frame than Steffi had just presented. A real strength of this data set is it's available, it's representative of the Northern Ireland population, and it has the ability to link across from different areas of government, and that's particularly useful for understanding society as a whole. First of all, the focus of the NILS is the health card registration system. This is the spine of the NILS data set. This is information everyone who's registered with the GP or health service provider. They have information on their address, and we have information on change of address every 6 months. So in terms of looking at change of residence and admission to care homes, this data is pretty key. Also, linking over from this healthcare information, we've linked the census, the 2001 census and information there, and also the death records. So that's the basic information we have about the individuals in this study. Additionally, in this case, we have information from the RQIA, the Regulation and Quality Improvement Authority, regulates and registers and inspects all care homes in Northern Ireland, so we can use that to identify if people are changing address and if they're changing address to residential or nursing home. Further, we have information from Land and Property Services, so that's the rates collection agency. We can look and get information about the value of people's houses. So in terms of looking at health inequalities and the experience of poverty or affluence and how that affects health, we can use that information there. Also, we have other information relating to just geography within Northern Ireland. So I'm going to talk about urban-rural factors in relation to these other household factors towards the end of the talk. Okay, just to look at that schematically, we have information on individuals as of Census 2001. We'll have information from a variety of sources that tell us about the characteristics of the areas, the characteristics of their house, and the characteristics of the family unit that those individuals are placed in. So we have 3 different levels of factors relating to individuals. From the Regulation and Quality Improvement Authority, we have information on all people who were in care homes and what care homes were operating in 2001 and since. And from the health card register, we have information on change of address. So in this case, we're looking at change of address every 6 months between 2001 and 2007. From that, we can see people who were living in their own homes and now they've moved into a care home. This isn't just in terms of respite care. This is people who've changed address. This is permanent moves into care. Also have information on death records. In this context, dying at home is a success. It's a good death. As Steffi was saying, most people would prefer to stay at home rather than have to spend their last years in care. So with this information, we can account for the people who died in their own home with their families. In terms of the statistics behind this, so in 2001, there were just over 51,000 people over the age of 65 who were not in a care home. We followed them for 6 years, looking to see for change of address, and over those 6 years, about 4% were admitted to care. In terms of the analysis I'm going to present to you, this is based on a proportional hazard, so most of what I'm going to be talking about is relative differences. So it's looking at the difference in characteristics between people who were admitted to care homes and those that weren't, and also the difference between people who were admitted 6 months after the census compared to those admitted 6 years. So it's looking at, it's not just the people who do and don't, it's looking at the risk of being admitted at any point in time. So it's looking longitudinally about risk of admission. I think I'm going to talk very briefly just about these factors. The 2 arrows here, the blue represents people below the age of 75, orange 75 to 84, and a grey over the age of 85. So males here, females on the right. You can see there's generally more females over the age of 85. This is the gender difference in life expectancy. The other 2 columns here, this is the proportions who were admitted to a care home, and you can see much higher rate of females, and this is due to their greater age. This is the fact that age explains to some extent why people are admitted. For these bars here, blue represents good health, orange is fairly good, and grey is not good health, again for males and females. The same pattern here can be seen in terms of the proportions that are admitted. People in worse health are more likely to be admitted to a care home. So this is the individual characteristics. If people have a long-term chronic condition like Alzheimer's, or if they're physically frail and not able to look after their own personal care needs, then they will need to get some support. They can either get that support in a care home or it needs to be provided in their own home. So in terms of the individual level of physical need, everything I'm talking about here is over and above these standard characteristics of the individual. In particular, I'm going to focus on the social characteristics that can relate to risk of admission. First of all, in terms of living arrangements, the literature generally would talk about living alone, being isolated, as placing people at higher risk. But what's the opposite of living alone? You can live with other people and you can get support, and there's not so much clarity about why living with other people would be protective in terms of admission risk. So to look at this in a little more detail, we broke into a few different categories. For people who were living alone, we looked to see their marital status. For this generation, marital status is a fair indication of whether or not they had children. So marital status here can say for those never married, they're less likely to have support from families who don't live with them, whereas the same isn't the case for people who are widowed or separated or married. In terms of those living with other people, there's the largest group is this 2-person households, people living with their partner. There's also, compared to the 2-person, larger households living with children or other non-family or siblings. You can notice here, living in a 2-person household is most common for males, although being widowed, again, this is to do with the difference in life expectancy. The difference in life expectancy is changing. The gap between men and women is closing. So this kind of structural difference in terms of women being more likely to be isolated, that's over time and in the future, that differential is going to disappear. So in terms of that level of isolation and the gender inequality, over time that will tend to reduce. Okay, in terms of these risk factors now, I'm going to talk a bit about relative risk of admission. I'll draw your attention to this white line. This represents the risk for people living in a two-person household. So this is people living with a husband or wife. So this is the baseline admission risk we're looking at. By comparison, we're now looking at people who are widowed. There's, again, males and females. This dot here represents about 1.45 times the risk. So for widowed people compared to those living with a partner, there's about a 40% higher risk of admission. These error bars, that's the worst case scenario, is about 90% increased risk. Best case scenario is about 10%, but overall we can be pretty confident there is a higher risk of admission among those widowed than those living with their partner. So again, having that support within the household is important for being able to stay in your own home. In terms of the never married, you can see there is a bit of a higher risk, particularly for males. So again, this suggests that having children who are able to provide some support, it's an important predictor of your your requirement for long-term care. It's not a huge difference compared to the widowed, so there's a smaller differential here than there is compared to living with a partner. Similarly, looking at people who are separated or married, it's not a huge difference here. Again, these are much smaller groups, so there tends to be a slightly increased risk for those who are living alone by comparison to those in the two-person households. Next comparison, again, compared to those living with a partner, what about those living with siblings? Again, this is an interesting comparison. Looking at siblings and spouses, they're both family. They're both about the same generation or the same age. So in terms of the ability to provide support, it should be reasonably comparable. Yet there's still a much higher admission risk for those living with siblings. That suggests there's something rather important about the partner, the spousal relationship itself. This is probably a lot to do with providing personal care or providing intimate social support. So it's not just living alone or living with another person, it depends who that person is in terms of admission risk. Looking at partner and other people, so again, this is comparing two-person households to 3 or 4 or 5-person households. The error bars here are saying in the worst case scenario is worse, the best case scenario is better. If we can't tell whether it's better or worse off, that's the statistical way of saying there is no significant difference. So in this case, there is no difference between living in a two-person household and living in a 3-person household if the other people are non-relatives. So again, just presence of people in the house, that doesn't necessarily equate to more social support. Living with children, so this is people who are widowed, but rather than living alone or living with children, this is equally supportive as living with a partner. So again, there's something perhaps important about having children, so it's a direct family that seem to provide good social care. And then looking particularly for males, living with a partner and children, this is an increased protective effect. So living with other people isn't necessarily protective, but living with children or the spouse is. In particular, living with both, this extended family living arrangement seems to be particularly beneficial in terms of social support. Okay, in terms of, I mentioned a bit about the idea of health inequalities and affluence and deprivation differences. There was information in this data set about housing tenure and house value. In the census, there was a question about if people had a mortgage or whether they were in social rented or private rented accommodation. So this tells us people who are on the property ladder. The value of the house tells them, we can see, are they on the bottom of the property ladder or at the top? And then we can see people who are in social housing who don't have the economic capacity. So in terms of looking at their health, the green bars here represent being in not good general health. The blue bar represents having a limiting long-term illness or chronic condition. The bars here, this represents people in rented accommodation, and then with 5 categories of house value. This is based on 2005 economic situation. But you can see here there's a clear trend for the people in social renting. About 80% of them aren't in great health by comparison to the people at the top of the property ladder, about 50% of them. So it's a massive difference. But it's not just people in some areas that seem to have bad health. At every point along the affluence spectrum, there's a change. So this is a very clear example of a health inequality. This is not just deprivation, but affluence and inequality in wealth at all points is related to long-term health outcomes. Okay, in terms of looking at the same information, but over and above the differences in health, looking at risk of admission. So here the comparison is the social and private renters. Every other category here seems to have about a 20% lower risk of being admitted to a care home. And there's no longer this gradient with increasing house price. It's just a binary difference. If you own your home, about a 20% lower risk of being admitted to those here in social rented accommodation. So this isn't to do with health primarily. It seems to be something in particular to do with owning property, and that should be over and above anything to do with health. And the most likely situation is this means that homeowners seem to receive a different amount of informal care, or can get a greater level of support from their families. Finally, just the last difference. I'm going to talk about urban and rural areas and the differences in the characteristics that I've mentioned so far. So to begin with, general health differences in urban and rural areas. Blue represents good, fair, fairly good, and the green is rates of not good general health in this group. So in urban areas, about 30% of the population over 65 aren't in good health. Then we have intermediate townlands and rural areas coming close to about 23% here. So there's definitely a difference between urban and rural areas in terms of the actual experience of good or poor health. So do bear that in mind. There's something about rural areas, either it's the composition of the population or it's their it's the lifestyle itself that seems to support better health. Then in terms of the living arrangements I'd mentioned, so the three bars here are urban, intermediate and rural areas. Looking here, this is the proportion of people in these kind of areas who live with a partner in a two-person household. It's much less common in rural areas to live in a two-person household. Like in urban and intermediate areas, it's more common. Similarly, living alone in older age, it's much less common in rural areas. This really seems to be an urban phenomenon for these smaller households. The reason that where the shift away is into larger extended families. In rural areas, much more common to live with a partner and children, or also with children and siblings. Now, if you remember back, these are the two living arrangements that are most supportive to the health and well-being of older people. So there's definitely something different between urban and rural areas in terms of the level of social support that is provided to older people in those areas. And finally, just looking again, by comparison to people in urban areas, no real difference in risk for those in intermediate, but there's about 25% lower rate of admission in rural compared to urban areas. So this is over and above the differences in individual health status. This is above and beyond the difference due to the social support from their family or whether or not they own their own home. There's still something different about rural areas that suggests that older people living in those areas don't often need to rely on formal care services. Okay, just to quickly recap. So in terms of living arrangements, variation in support is most important in terms of the support of people in the home. Having the availability of somebody who doesn't live with you in terms of having maybe family or neighbours, it does make some difference, but it pales in comparison to having support from relatives, in particular close relatives, spouses and siblings, or spouses and children, sorry. So in terms of the long-term trends, In urban areas, certainly, it's much more common, and projections would suggest that there's going to continue to be more two-person households and more older people that will be living in single-person households. So that means the people at the highest risk of being admitted to a care home, this is going to be the dominant demographic group for the older population. So with less availability of informal support, or informal support being less able to provide for their needs, that suggests we'll either need to increase the level of formal services, or policy will need to look at changing household structures so that they are more supportive. Also, in terms of home ownership, there was a consultation out in terms of changes in reform of adult care, and one of the real messages that came through in that is that people are very resistant to the idea of having to sell their homes to pay for the cost of their care. This is genuinely unpopular in terms of the way that this was originally portrayed in terms of the right to buy. It was about being able to leave a legacy to your children. So the idea that some people may have entered the property ladder to leave an investment for the next generation, and then upon entering care that will be withdrawn to pay for care. It seems to be particularly unpopular. Also, in terms of the fallen house values, it may not be an adequate source of finance to cover the cost of care. So in terms of that as a model for care home financing, there may be something else may be necessary. Finally, in terms of rural areas, I know I'm short on time, so there seems to be something different in rural areas, and we need to see, are there lessons that can be learned in terms of the living arrangements, and is there a difference in cultures that suggests that in rural areas people are more willing to live with their adult parents while they have a family of their own? Or is it a little more structural than that? Is it that there's larger houses in rural areas so people are more able to accommodate their elderly parents? If that could be related in urban areas, that would suggest, is there a change in culture, or would there be a real benefit in having spare bedrooms and extra capacity to take on board a parent in the event of their widowerhood? But more generally, above and beyond these factors, there is the question, is there a differential deployment of home care resources? So rather than relying on placement in long-term care, is there a difference in provision of home nursing or home helps? If that was the case, then the question is still whether could that be replicated in urban areas. Okay, sorry, I've thrown a lot of information in a short space of time, but very happy to answer any questions on that. So thanks very much.